Well, it's a great pleasure for me to introduce for the main lecture our speaker, Peter Fonagy. I have the strong feeling that Peter Fonagy is the most important people for build bridges between psychoanalysis and new knowledge on the brain. And he has also the capacity to have introduced assessment on psychodynamic psychotherapy. And for these two reasons, I think he is in our field the man who has prepared the future. So it's for me a great honor to introduce him. Everyone know Peter Fonagy. I just recall that he's psychoanalyst, he's a chief executive at the Anna Freud Center in London, and he is also professor at the University College London. Peter, please.
That's nice. If you just keep on, sorry. No. Thank you very much, Philippe, for the introduction. And can we just have a little bit more light, because I can't actually see what I'm supposed to be reading. Thank you. It's an enormous honor that I want to thank Ernesto Caffo for and the program committee for having invited me. It's an enormous honor to be here. If the slides interest you or intrigue you, there's my email address. I'd be delighted to send you slides. It'll appear at the end of the talk as well. I have my entry ticket for this presentation is this pair of books which I wrote with Anthony Roth, Mary Tage, David Cottrell, Janet Phillips, Serena Kurtz. And in addition, I would want to acknowledge the inspiration and help of in this talk of Peter Fugel, Dick Bevington, Miranda Wolpert, and they will see that I draw on their ideas extensively. Now, these books are born of a movement that's called evidence-based medicine, which is really a move from a do this, do that medicine to why to do this or why to do that. And it's moving medicine from a big heart but small brain to Mother Teresa's heart and Albert Einstein's brain. Well, maybe it's a little bit optimistic. Anyway, it is said, but the intent is to increase certainty at the expense of intuition and unsystematic clinical experience by strengthening the grip that we have on cause-effect relationship. And the main tool in this is the so-called hierarchy of evidence, which is based essentially on the methodological character of studies rather than their quality. And I'll come back to that quite a bit in my talk. So whilst evidence-based approaches can improve the rigor of medical practice, evidence-based should never be misunderstood to be synonymous with best practice. But it has achieved a great deal for us. And if, for example, you look at the studies of the efficacy of SSRIs against placebo, you notice dramatic differences between fluoxetine, paroxetine, sertraline, citalopram, venlafaxine. And of course, what you're interested in is those error bars. And if they touch the zero, then the chances are that actually the drug has no effect, and the number needed to treat before you notice an effect is actually quite large. And fluoxetine is clearly the only one that looks promising, sertraline coming close second. That's interesting. There's an article in this year's European Journal of Pediatrics by Clavin and colleagues from Milan looking at prescription rates in Italy for SSRIs, which shows that indeed sertraline comes top of that list, paroxetine comes second, citalopram third, and fluoxetine fourth. So there is a difference between the evidence and practice that we should know. That was data from 2004, so it may be very different now. So there's much that evidence-based medicine has achieved for us. We have a research and practice-oriented set of questions that we can answer. As I said, we have a grip on cause and effect reasoning that's analogous to laboratory research. There is a methodology for regrouping experiences from multiple sources, meta-analysis, and I shall talk about that quite a bit. There's methodology for systematic reviews, ways of communicating about the magnitude of effects, number needed to treat, number needed to harm, structuring literature searches and findings, and clinical appraisal. However, ideologically, evidence-based medicine is strong. Philosophically, evidence-based medicine is somewhat weak. And it's widely adopted, but I think we mustn't allow ourselves to be accused of committing an ad populum fallacy, that is, that just the spread or acceptance of an approach in a sense justifies it. And if you look at the definition of evidence-based practice, the classical definition, evidence-based medicine is the conscientious, explicit, judicious use of current best evidence in making decisions about the care of individual patients. This is full of motivations, but which of us would put our hands up and say, well, actually, I'd rather be not terribly conscientious and not terribly explicit, and I really am fed up with being judicious, and I'd actually far rather be unsystematic than systematic. So, what is it that defines a practitioner who's evidence-based? It seems to me that most evidence-based medicine definitions are inspirational. They are motivational, persuasive, essentialist, but they do not actually stipulate or operationalize what is meant by it. Now, let me actually focus on psychological therapies in this talk, because that's actually what I know about, and I thought I'd break a habit of a lifetime and in this talk and actually talk about something I do know about, as opposed to many things that I do not, as my colleagues will bear out. In the world of psychology, according to the American Psychological Association, psychological therapy is evidence-based if it has been compared to a no treatment control, an alternative treatment control group in a randomized control trial. It has been statistically significantly superior to it. It's actually been replicated by a group other than the original investigators, and it's well specified and has manuals, and the patient group has been well specified, and so on. And this kind of methodology is what the tail that wags the dog. If you meet these kind of criteria, then in a sense it matters less what the study is about. It will meet criteria for being evidence-based. But there were some of the originators of the evidence-based approach who warned us about this. In fact, Cochrane himself said between measurements based on randomized controlled trials and benefit in the community, there is a gulf which has been much underestimated. And another founder of the movement, Bedford Hill, wrote, At its best, a trial shows what can be accomplished with a medicine under careful observation and certain restricted conditions. The same results will not invariably or necessarily be observed when the medicine passes into general use. Now, before you consider me a hypocrite, publish these 2 books on evidence-based psychological therapies for children and for adults, I want to just nail my flag to the mast and say that randomized controlled trials, in my view, are the most reliable methods for determining moderate treatment effects. They must be internally valid, that is to say that design and conduct must keep to minimum the possibility of bias, but in its modern meaning, the relationship between cause and effect is tightly demonstrated, and it differentiates what we do from faith, from believing something and that making it true. Because really, if we're honest with ourselves, actually, probably better at comforting patients than we would be. If there's nothing else that differentiates us from them, because we are both working on faith, then it's probably best that we don't do what we do, because probably not quite as good at it as they are. But at the same time, I would like to emphasize that we shouldn't replace one faith with another. We shouldn't replace faith in classical, whatever we were practicing, with the faith in evidence-based medicine as a new religion. So that's really what my talk is about. And this is really the big but. Clinically useful results have to be relevant to a definable group of patients in a particular setting. This is the issue of generalisability. And that's really what I would like to address in this talk. Before doing that, let me just quickly overview the evidence, and I'll be really very quick about it. These are the meta-analyses, the summaries of evidence that are out there. Broadly, what they show is that 3/4 of the patients treated with psychological therapies are better off than the average untreated person. And, an effect size of about 0.75, and that's where it's about, is a moderate effect size. Anything about 0.8 is strong, between 0.2 and 0.5 is considered small. However, having a moderate effect size is, as Philip Graham underscored in his talk, elegant talk. I really very much enjoyed it, and in fact found myself, unfortunately, in agreement more or less everything that he said. I wish I could say different, but sadly. If you group disorders into kind of 4 major categories into children, anxiety-related conditions, then the modeling, reinforced exposure, CBT, have been shown to be very effective. For depressive symptoms and disorders, evidence-based treatments are CBT, interpersonal therapy, activation therapy, a form of behavior therapy. For ADHD, evidence-based treatment, CBT, relaxation, biofeedback training, surprising, not often practiced, behavioural parent and teacher training, conduct-related problems and disorders, youth-focused operant treatment, cognitive behavior therapy, particularly problem-solving skills training, behavioural parent training, and multi-systemic therapy. And let me also put in a plug at this stage for the summary of this literature in this very volume that Miranda Wolpert and her colleagues assembled, that's actually designed for children and the parents. So I think mental health professionals will derive a great deal of benefit from looking at it. It's evidence presented simple enough for children. It should work for child psychiatrists. I did not mean that. It just slipped out. I'm really sorry. However, let me make a couple of additional points here. That when you look at these treatments, and they are individual evidence-based treatments, what you find is that a lot of treatments, for example, the treatments for effective therapies for depression, a lot of different therapies coming under different labels actually share a lot of features. And I think this was touched on by Philip Graham very effectively. So promoting competence is shared by all of them. Self-monitoring, addressing relationship skills, almost all of them. Communication training, child psychoeducation, problem solving, cognitive restructuring. It's there in two-thirds of them. Involving parent-child relationship, relaxation, about half. So they have common processes. And indeed, there are common factors that predict outcome, particularly good outcome and also dropout. So if you perceive a therapist as not invested in you or as a parent or as a child, you're likely to drop out. If you perceive the therapist as incompetent, you're likely to drop out or not do very well. Therapeutic alliance reduces dropout and increases effectiveness, creating a sense of hopefulness about the treatment. Again, increases effectiveness. Behavioural participation outside the therapy, getting you engaged in your general life, again, increases the quality of outcome. None of this is rocket science. But there seems to be a problem with the take-up of evidence-based practices. And given that most evidence-based treatments are cognitive behavioural, just looking at the number of people who are accepting the label cognitive behavioural is actually quite an interesting answer. So most everyday, according to recent surveys, most everyday clinical practice with youth is non-behavioural, is eclectic, systemic, or psychodynamic. Clinical trainings for psychologists and psychiatrists. Actually, the interesting thing about this is that in 1993, they were more closely related to the evidence than they are at the moment. So 11 out of 22 evidence-based treatments were taught in these trainings. In the more recent survey in 2003, only 5 out of 22 of these treatments were taught as part of training. In a UK survey, the CBT is accepted as a dominant approach by only 20% of respondents. So there's something is wrong with the logic of the way we are doing things. And there is a gap, and the theme of this Congress is building bridges. And I'd like to contribute a little, but bridging the gap between research and practice in at least this area. Now, the 3 areas of concern here. Firstly, and that's what I'll focus on, the generalisability of the research evidence. That's the kind of the blue circle there. Secondly, the patient characteristics and the healthcare settings that these evidence-based treatments are supposed to be practiced in. And they may provide a poor match to the research evidence, but also they may provide a poor match with what patients' expectations and preferences are. What I want to focus on is really what I consider to be the institutional neglect of generalisability. The generalisability of the evidence, the generalisability of the reality of the clinical setting, and the generalisability of patients' experience and expectations. So why do I say there's an institutional neglect? Well, there's a great deal of research into the internal validity of randomized controlled trials and systematic reviews. And this massively outweighs research into how the results could be best put into practice. There are tons of rules governing the performance of trials, but no similar literature on external validity. drug licensing bodies do not require evidence that drug has clinically useful treatment effects, or a trial population is representative of routine clinical practice. Guidance on design and performance of randomized controlled trials from funding agencies such as the NIMH or MRC makes actually virtually no mention of external validity. Ethics committees talk about how research should be internally valid, but they make no recommendations about generalizability. Guidelines on reporting randomized controlled trials, such as the consort guidelines, they make mention of how to report validly, but they give very little space to external validity. There are, in fact, no accepted guidelines on how the external validity of randomized controlled trials can be quantified or assessed. Now, the problem is that we know that randomized controlled trials are necessary because they're very good at eliminating biases. And biases are there, I mean, we can deny it. We say, I'm not biased, I'm open, I'm just so open to hearing new ideas, it's unbelievable. But actually, when you look at randomized controlled trial literature, and I kid you not, this is an empirical finding, you can predict something like 3/4 of the variance in the findings of randomized controlled trials from the declared allegiance of the author, the first author of the paper. So if you just know what the allegiance of the first author of the paper is, you don't need to read the rest of the trial. You know what the outcome is. Randomized control is necessary because we are biased. And randomized control trials, by blinding treatment allocation, by using placebo control, by excluding, because of the randomization, patients and clinicians who have strong treatment preferences, they reduce bias, but this has consequences for generalizability. You might get an underestimation of the beneficial effects of clinical practice because clinical practice is biased. Because, as actually Philip Graham pointed out, it requires our enthusiasm. Especially, this is the case for so-called patient-centered outcomes. Let me give an example from a different field that will illustrate the problem. Now, early breast cancer sufferers have a choice of a lumpectomy or removal of the cancer by mastectomy. Now, in a randomized controlled trial, comparing these two approaches, you need to find women who are willing to say, I don't mind what you do to me, which of those two alternatives you're going to carry out. The question is that population, which is 10% probably, who agree, is that representative? And that's not a problem if there's a massive difference between the two conditions. But if the two conditions are only marginally different, then one would expect that the outcomes, especially on psychological well-being and so on, that follows the operation, would be greatly affected by whether the person preferred this or that procedure being performed. So the outcomes, as it were, are dramatically restricted by the methodology. Let me turn to another issue. There are major cultural differences that affect randomized controlled trials. There are, in this audience, I really don't need to talk about this, but there are major national differences in diagnosis and admission rates, in the speed with which patients are investigated, in the profile of problems. For example, that in a recent trial of psychotherapy and family therapy by Judith Strahl and colleagues, the kind of problems that is associated with major depression in Greece and in the United Kingdom completely different, very heterogeneous groups. And it was a multi-center trial. But there's also a difference in diagnosis and management. For example, the well-known differences in the diagnosis of bipolar disorder, the treatment and normal treatments, stimulants, for example, and its prevalence being quite different in Europe and US, UK increasingly. But even more important, there's striking differences in the so-called ancillary non-trial treatments, what our social services provide for individuals in different countries, which are actually likely to be very influential in the outcomes, in the effectiveness of any treatment, an evidence-based treatment. And yet, 85% of the evidence for certain psychological therapies that is used by the United Kingdom authority, the National Institute for Clinical Excellence, that recommends treatment protocols for mental health professionals and other medical professionals. 85% of that evidence comes from trials in the United States. And that, to me, is puts a major question over the generalizability of those findings. There are very few large psychosocial trials in the UK, and the recent trial by Ian Goodyear, late DeCouton, and others is really an unusual one on major depression. It's well worth looking at. There is also an issue of selection of clinicians. In some systematic reviews, all the RCTs that are reviewed are based on university clinics. Treaters in randomized controlled trials differ powerfully from professionals in terms of their goals, in terms of work pressures, from those who actually work in real practice. The usual clinician just can't afford to specialize in a single problem. And they have to treat a broad area. And when they apply an evidence-based treatment, they apply it for that patient between 9 and 10, and then there's a whole bunch of others that come who they have to use different approaches with. In some trials, therapies with poor outcomes actually are known to be routinely rejected at the outset. So, if you don't do very well clinically, you're monitored and you're excluded. Now, obviously, everybody in this room is an above-average clinician. We know that. But in reality, out there, outside this room, there are clinicians who are below average in terms of their effectiveness. But those are eliminated from a lot of randomized controlled trials of psychosocial treatments. So you have also often specially selected therapists. I mean, it's rumored. I don't know whether it is true, but it's rumored certainly that a lot of cognitive behavior therapy trials of anxiety and depression actually use psychodynamically trained clinicians to administer the cognitive behavior therapy because they are better at relating to the children. This may be a rumor, an urban legend. Another thing about evidence-based therapies, they involve learning from a manual, which takes away from some of the spontaneity. But actually, that's not so much the problem. It's actually very difficult to deliver a manual spontaneously. You have to be very highly trained before you can do it. You have to learn your lines, basically. If you're doing it from here. But the next thing I have to ask you is, can you tell me about your... it's not going to work. Learning evidence-based assessment is another challenge. There are also the staff therapists who apply evidence-based practice. They don't know the developer. They don't have a personal relationship with the person who developed the therapy, and therefore they're not so interested in carrying out that effective. They're not so invested that, oh, well, you know, Professor Goody won't like me unless I do this trial properly. Not, you know, so it actually is, it's a challenge. Anyway, moving on, there's also obviously a well-known problem of the selection of patients. Patients are actually pre-selected for trials. This is less well known. When you look at a console diagram of where patients come from, they usually work from the percent of cases referred. Now, any university centre that runs a trial gets referrals from a wide range of other clinics that supply it. Now, a lot of people who work in those clinics know the kind of patients that university centre is looking for, and they will not refer a patient that they think, you know, they won't like, and they'll be referred back. So that actually even the top line is not representative of the real patients. So actually it's quite difficult to generalize from trials because of that eligibility bias. But it has been calculated that when you compare to community studies, in some trials of certain disorders, it could be that the representativeness is maybe just 1% of the patients who served in a trial, completed a trial, that are actually 1%, 99% of individuals who may have the same kinds of problems out in the community never entered the trial. Eligibility criteria such as age, comorbidity, family adversity are well known. In the US, when they looked at this in the National Institute of Health, they found that the average exclusion rate was 73%. That's almost three-quarters of patients being excluded. So it's not, you know, there is a generalizability problem. But it's worse than that because it introduces a bias in terms of the kind of patients that are seen in the trial. You know, the most severely disturbed, the most comorbid, the individuals who miss appointments, they drop out of treatment, they will not be selected for trials. And the problem is here that if you have a treatment that's built on, say, a skill that has to be acquired, that requires the family to attend regularly in order to learn the skill. Well, if they don't attend regularly, they won't learn the skill. So you have to have an evidence-based treatment that actually works for patients who are bloody-minded and they don't want to attend. And there are very few, in my review of the literature, very few evidence-based treatment for bloody-minded families. Obviously the reason for seeking treatment is very important and demonstrated empirically to be important. That, for example, the desperation with which some families come, or the court sends them, actually is not represented in randomized controlled trials. And there are Cinderella groups who very few trials on. Anorexia is a Cinderella group like that, even though the annual mortality from anorexia is 12 times that of a normal adolescent or 15 to 24-year-old. And there are, a handful of trials actually showing really not terribly promising results. Substance abuse in youth is another area that's underserved. ADHD in adolescents is another area. There are actually 150 DSM diagnoses that could have a trial applied to them. And obviously this is not how it can work or will work. If we look at how representative trials are, only 13% of trials had study samples of clinically referred individuals. Only 19% employed at least one practicing clinician. Only 4% of studies was treatment provided in an actual service setting that was separate from the research. Only when you combine some of these criteria, only 1% of studies, this is out of hundreds of studies, include at least one practicing clinician, clinically referred children, and some treatment carried out in service setting. But I have to say this is changing. there is increased emphasis on effectiveness, so-called effectiveness research in favor of efficacy research. But really this is coming at a price. Now, these are the effect sizes from 24 trials of depression that I grouped according to year of publication. That's the effect size there, large, medium, small, and year of publication. Can you see a pattern there? The regression is 0.63. There is a dramatic decline in the effectiveness of the same treatment as time has goes on, as I think trials have become more realistic. And this is the pattern of results that I think Philip Graham also referred to. But actually, the pattern is the same in relation to evidence-based treatments for 55 psychosocial interventions for disruptive and aggressive behavior in children. It's a smaller regression, but the pattern is the same. So 68% of the large effects were before 1995, and only 15% after year 2000. I mean, I don't believe in kind of predicting trends, but it's not pointing anywhere very good, that line, is it? Now, the point I want to make here is surely, if we were a work in progress, if we were moving towards something, that line would be going up. Effect sizes would be increasing across the world. But effect sizes seem to be decreasing. There's something that's the matter. The comparison of effect sizes looking at effect sizes in comparisons of evidence-based treatments with usual care are really excellent. That's very surprising. In the child and adolescent literature, there are only 32 randomized controlled trials of psychosocial treatments with 36 involving 36 therapies that compared to treatment as usual. So treatment as it was happening in the clinics. Okay? People are often very rude about what ordinarily happens in clinics. Yet, 62% of evidence-based treated patients, only 62%, are better off than the average normally treated child. Just 12% that you make a difference with. The mean effect size is 0.3, and the mean effect size is 0.3, and it actually touches that critical minus barrier. 22% of effect size are medium or large, 38% are small, and 41% are negative or insignificant. So what this implies is that we actually need to look at seriously what's happening in usual care. We should study usual care with care. Manualizing, perhaps, what's happening in effective usual care protocols, comparing effective and ineffective protocols, and the kind of initiative that the Cork Partnership in the UK have undertaken, measuring outcome routinely, will give us a handle on this, one hopes. Psychosocial interventions normally tested on basically in a pharmacological model, and that might not work very well. So we try and do the best we can and demonstrate optimal efficacy, and then we translate it, disseminate it, give it out to the clinics. Well, this is obviously evidence-based, you do it. Now, this doesn't seem to work terribly well as the model. Doesn't get taken up, but maybe it's not even very effective until it gets out there. And really, perhaps what we should do is something a bit the other way around. We should develop, in conjunction with clinical practitioners, the evidence-based treatments. And this is what John Weiss suggests in the kind of deployment methodology that he has put forward. Let me, even in that context, we need to measure outcome. Let me say just a few words about measuring outcome. Now, in trials, outcomes are often proxied and often not clinically relevant, and there are problems in arbitrary scales. In fact, a review of 2,000 randomized controlled trials of schizophrenia identified 640 scales, which were devised, some of them specifically for that randomized controlled trial. No data on validity and reliability. And in fact, not surprisingly, unvalidated, unreliable scales are more likely to show a big outcome than established scales. But this is not really the point that I want to talk about. The point I want to talk about is that the scales that we use are often scales that we think are relevant. And in fact, there's a massive difference between what patients think is important and what clinicians think is important. This is data on multiple sclerosis. There's no good data from child mental health. But what patients think important, patients with multiple sclerosis, are things like mental health, physical function, physical role limitation, general health, vitality. These are things that what patients think are important. What clinicians think are important are particularly, as you can see here, physical function, physical role limitation. Mental health, emotional role limitation, and social function are important for the patient. They agree about some things, social function and body pain. But if you look at the literature on multiple sclerosis, it is physical function and physical role limitation that's most often measured, which are just outcomes that are not that important for patients. Even more important is something that Alan Kasdan and colleagues have pointed out. Most of our measures in child mental health correspond to what we would like, what we can call arbitrary matrices. Let me just confront you with a remarkable headline from a major newspaper, not true, that I read the other day. Depression is reduced, Brussels sprouts. So, BST, Brussels sprouts therapy, reduces depression in children. Now, what this actually under self-report ratings of depression indicated change that supported the proposition. Now, the question is how much change in depression occurred that's demonstrated by the measure. Does the change relate to how individuals are doing in everyday life? The more we believe in BST for depression, the more likely we are to lose sight of the actual metric. We are not sure that any of these changed. The measures that we use are arbitrary, but we reify them. Height and weight are real, and they're not correspond to an arbitrary metric. But something like depression, we don't know really what a small or a large change is on most of the measures that we use. Let me now turn to the thorny issue of common factors that, again, Philip Graham has touched on. Is therapeutic relationship more important than specific techniques? In Philip Kendall's study on coping cat that he mentioned, children rated their relationship with the therapist as the most important aspect of their treatment. The controversy in the adult literature is relevant here, that a lot of the variability in randomized controlled trials, but particularly in community-based not randomized, not experimental, observational trials, is actually accounted for by the individual therapist. That actually in one major insurance study, there was an outstandingly successful, the insurance company looked at all their therapists in terms of effectiveness, and there was this one therapist that was outstripping everyone else in terms of their effectiveness. And they called this person in, they said, we want to know what you did. There's this little old lady that came in, said, hello, dear. She was the most effective therapist there are no manuals on how to get a child to like you. I mean, maybe you know one. Can the person who knows one... So I want to become a more effective therapist. Anyway, it's really quite an important point, that we learn what is positive about a therapeutic relationship, what therapist behavior fosters it, can it be taught and trained, and so on. Now, narrow and broad treatment approaches, and this is a very important point that I'd like to underscore. Evidence-based treatment force us towards increasingly narrowing our treatment approach, where we have specific treatments for particular disorders, because they appear effective in meta-analysis, because specific outcomes are larger, and it also is much easier to do research on. It provides a kind of context for doing research. But we know from the work of Adrian Angold and many others that actually comorbidity is completely all-pervasive, both in clinical samples and in the community. So what we need to perhaps do is reverse this trend for overspecification and create effective generic but focused treatments which pertain to single critical capacities. So that these are treatments that involve disabilities or problems that children share who have problems, maybe self-esteem, maybe affect regulation, maybe mentalization, and we have a treatment that's focused on it, but it's applicable to a wide range of children. And the mentalization-focused family therapy, which I, and Mehtage, Pascal Furion, Laurel Williams, Efraim Bleiberg and I are working on, is one of them. The integrative multimodal practice that Dickon Bevington, Peter Fugel, I, and Mehtage and I are working on. These are examples of it, but there could be many, many more that need to come out. Now, this takes me to the issue of mechanism. We know far more about the outcomes of treatment than we know about what produces good outcomes. And what will happen is, as Skinner, one of the people that you didn't mention, I don't know why you left Skinner out, it mentioned, it's a major adversary. Anyway, he's pointed out that when we don't have proper feedback, proper contingency, we indulge in superstitious behavior. So we'll start developing just new therapies that work because we are reinforced positively by them working, in much the same way that he indicated in his anecdote. But we have in excess already of 500 therapies. It's too many. I mean, it can't be, I feel like it's like washing powder. There are all these, you go to the supermarket, you see 100 washing powders, everybody says the best one, say new on it. And you think, well, probably what's in it is soap. It's probably just soap. It probably is. Anyway, so different ways of delivering it. But say we know that multisystemic therapy and therapeutic foster care program both work by reducing delinquent peer affiliation. But we need to understand mediators, understand impediments, understand stalls in therapy, to understand failures of therapy, and to focus on targets. What we need is a cross-cutting set of principles to combine and redesign and refine our intervention. So, what the gaps in outcome research are, I'm coming to a graceful conclusion here. There's no good evidence, really, for who will benefit from what type of psychotherapy. Our therapies are inexact, they're partial in their effectiveness. And then we become attached to methods. And there's a guildification of interventions. Yes, but, how many of the trainings have you done? And there was quite an interesting difference in the... Professor Kim did a little survey here in this audience of how many people were trained in CBT versus practice CBT. And interestingly enough, there were fewer trained than practiced, which is interesting in itself. But what happens is that we become invested in these training schools, and we then want to push our own line. And you have to jump through hoops in order to be accredited. What we need is a new intellectual framework for psychotherapy. We need to develop a scientific basis Thank you very much. There you have the neural, psychological mechanisms that underlie a problem, and that we then try to specifically design treatment to address those dysfunctions and develop these treatments in the context of real clinical services. We continuously monitored them, and there is, I think, a consensus that in this context, the social relationship that the family and the child has with the treater is critical. Now, interestingly enough, even the American Psychological Association has recognized this, and they have, to some degree, gone back on that evidence-based treatment notion and produced a new model, an evidence-based practice of psychology, which is an integration of the best available research with clinical expertise in the context of patient characteristics, culture, and preferences. And in this context, a decision-making process, rather than an assignment to a particular type of treatment by a mechanistically determined body of evidence, that is able, a decision-making process that's thoughtful, that integrates multiple streams of research evidence, including but not limited to randomized controlled trials, is what's used. Evidence, empirically supported treatments, ask a simple question: does it work? EBP, evidence-based practice, asks questions: what research evidence will assist the psychologist in achieving the best outcome for a specific patient? It encompasses a far broader range of clinical activities than just the treatment. It includes psychological assessment, case formulation, and the therapeutic relationship. A range of empirical methodologies are recognized depending on the kind of questions that you ask. So clinical observations for innovations and hypotheses, qualitative research, systematic case studies, single cases, a much wider range of research methods, and move away from a dependence on randomized controlled trials, although randomized controlled trials remain relevant. But most important, there is room for clinical utility, the applicability and feasibility, usefulness of the intervention in a particular setting. With diverse patients, how robust it is in that setting, how feasible it is to actually implement that program, and how much it costs. Related to this is that it should mesh with the patient's theory of illness and cure. And this has cultural influences that I don't have time to go into, but above all recognizes that psychological therapy, but actually all kinds of medical, is a collaborative exercise. It's between patient and patient to negotiate working together, and that the patient's values come into this, and they must be central components of evidence-based practice. The consensus of the task force is that a given clinical circumstance, psychologists of good faith and good judgment may disagree about how best to weigh different forms of evidence. Over time, we hope, and it's an aspiration, that systematic and broad empirical inquiry in the laboratory and the clinic will point the way towards best practice in investigating evidence. So, in conclusion, science is good for practice. Which form of care is best for children? What causal mechanisms play a role? What circumstances can interfere with the treatment working? But practice is also excellent to science. Where knowledge is most needed, we can find out. Where science can be grounded in everyday care. Best evidence is only meaningful when used with proper argumentation and a broad range of evidence. And argumentation is only meaningful if based on best evidence building blocks. But again, I'm not the first person to say this. Jules-Henri Poincaré has pointed out, science is built up with facts as a house is built with stone. But a collection of facts is no more a science than a heap of stones is a house. So, thank you very much.
Thank you, Peter, for this very stimulating and clever, brilliant speech, as usual. Thank you, and I think we have a little surprise for you. Turn back and...
In the name of the Congress, I'd like to recognize Mr. Peter Fonagy, in particular because it's the symbol of this Congress, bridging the gaps between psychopathology and neurobiology, and I think the last slide gives the sense of this bridge. Thank you very much, Peter.
Well, we can close now. No more. Yes. Okay. Thank you, Peter, and have a good day. Well. Brilliant.